Okay, I think I'm going to go ahead and start with the introduction. Welcome everyone to the Essential Substance Abuse Skills webinar series. My name is Ella Driscoll, and today Avis Garcia will be presenting clinical evaluation and screening. This training is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center. We are part of the ATTC network out of Iowa City, Iowa, right here. In the next couple of days, we will send you a follow-up email that includes a link to the recording, a handout of the slides, and CEU request instructions. We are a NADAC certified educational provider, and we are currently waiving all fees for CEUs throughout the pandemic. Again, the follow-up email will contain instructions for ordering your CEUs. Following today's webinar, you will be redirected to our GIPRA evaluation. This quick survey takes a few minutes to complete and asks about your satisfaction with the event. This feedback is critical for our future work, and we greatly value the opinion of your time spent with us. Today you will be muted for the duration of the webinar. Please use the chat to share your questions and comments, and we will address them as well as we can or address them in future sessions. There's also a Q&A box that we will be utilizing. This project is supported by the Substance Abuse and Mental Health Services Administration, SAMHSA. The content is developed by the presenter, and the opinions expressed to not necessarily reflect the views or policies of SAMHSA, HHS, or the American Indian and Alaska Native ATTC. Today we will be hearing from Avis Garcia. She's an enrolled member of the Northern Arapaho Nation and affiliated with the Eastern Shoshone Tribe of Wyoming. She earned her doctorate in counselor education at the University of Wyoming, and she is a licensed professional counselor as well as a licensed addiction therapist. For 19 years, she has been a mental health provider in the treatment of Native American youth and families. With that, I want to give a warm welcome to Dr. Garcia. Thank you so much for being here with us today.
Thank you, Ellen. And thanks to everyone who's taking time out of their busy schedules today to attend this webinar. You can switch the slide. We can get started. Today's session will address the screening process for drug and alcohol abuse patients. The first step in the process is to determine whether the patient recognizes that there is a need to change his or her behavior. And the next step in the interview is to interview the patient and determine whether he or she describes behaviors predictive of alcohol or drug abuse, and ask specific questions that will further describe the nature of the problem. And the presentation will progress through the material in the following order on the next slide. A patient's substance use, patient's substance use is not the problem, but rather a symptom of underlying issues that may be the cause of why they started using in the first place. So I want to say a majority of the time, these patients are struggling with underlying trauma issues. They may have mental health issues, co-occurring disorders, and this is how they've been coping, is by using substances. You can change to the next. Okay, we will discuss the clinical evaluation that includes screening. And we will do an introduction and overview, discuss the stages of change, facts about change, look at some of the brief screening tools, and just give you a brief overview of what they're about, and discuss the difference of screening and assessment. Screening for substance use. We'll take questions and comments at the end, and we will look at the DSM-5 screening and assessment, and some treatment options and modalities. As you see, that is time dependent. We have an hour and a half, so hopefully we can get to everything. You can go to the next. Okay, The first is looking at the stages of change, and this was created by Prochaska and DiClemente, and they are psychologists in the 80s who were looking at cigarette smokers and the change process. Since then, this has been used to characterize changes in addictive disorders, including alcoholism. But really, this can be with anything, like if you're thinking of changing your eating habits or you want to get more fit, looking at there are other types of addictions that we call process addictions, and those would be like video games or shopping or there are a lot of different things, and it takes people time to change, and sometimes it takes many times before they finally take action. Next. Prochaska and DiClemente came up with these stages of change, and they're usually shown in a circular model, with pre-contemplation being the first step. So this is where someone just starts to think that maybe I need to make a change. And contemplation, as they're thinking about it even more, they realize that, hey, this is a problem and maybe I should do something. Then there's the determination and preparation and action. This is actually taking part in the change process. And maintenance. Once they've reached their goal, the job then is to maintain. If they're in recovery, then we want to stay in recovery, and how do we maintain that? And then there's also the relapse and recycle. So quite common in substance abuse treatment, a lot of people have relapse, and they may have a moment where they are not sticking with their plan and they have a using episode. And then there's termination or graduation. Next. Here are the beginning of the stages of readiness to change. As I said, if you see on the right is the stage that's, or out of the left, pre-contemplation, and the right is the description. So, and when they're in pre-contemplation, a patient they're not considering change, and they may not see their behavior as a problem. And I have been doing drug and alcohol evaluations for several years now, and it's quite common to see people sitting in front of me that might be there for a DUI, or they violated probation by using, and they're there because the legal system is bringing them there, but they won't see it as a problem. So the trick is getting them to realize that maybe there is a problem. Contemplation, this is for individuals who may be ambivalent about the change and acknowledging that maybe there is a problem. Next. The stages of readiness to change. The next stage is determination and preparation. Here, the client is committed to making a change and has made a decision to change. So often when people are in recovery, I can sometimes tell those that aren't in that stage, and then oftentimes we encounter people who realize that, you know, I really need to make some changes here, and they're ready to learn. The next stage is taking action. They are involved in the action that they need to take and actively implementing a plan so that they can make the change that they want to achieve as a goal. Next. The next stages of the readiness to change is the maintenance, and this comes with the relapse cycle and the recycle. The description is the behavior change. They're staying sober. Some people may go to support meetings. They may go to counseling. Some people, it's fitness, whatever each person uses, attending their treatment classes. And this is the high confrontation level, and it's a new behavior for them. And they're working on addressing the undesired behaviors, which is the using that's causing the problem. And the recycle, the relapse cycle and the recycle it's quite often with any addictive disorder that some people will relapse. Very rarely, but it does happen. Some people go right through the treatment program. They don't have any relapses. They do everything they need to do. They follow all the rules. And then there's those that might do good for a while and then they use. So that's where the recycle is if we were to look at this in a circular model, they would start at the beginning again and go back to where they were. And for some people, it takes several attempts to be successful. So the first time doesn't always work for everyone. The final stage would be the termination or graduation. This person is stable and the problem behavior is resolved. So that's what we hope for everyone. Next. Here's the circle I was telling you about. As you could see, the pre-contemplation on the left-hand side in orange is up there at the top, and you can see that this is a cycle. This is a stage model of the process of change, and this is changing addictive behaviors, a perspective from the American Psychology Society. Next. Some facts about change. It is a natural process. Brief counseling can speed up the change process. Faith, hope, and efficacy are important elements. It helps to have other supports. Some insurance companies require family involvement at any stage if possible. And it's good for them to find positive people that they can socialize with so that they're not socializing with other users. And counselors do matter. And it's not that we make the change for them. We're there to support them, and the main thing is being there to listen to them. A lot of times I've heard patients say, you know, my dad doesn't want to hear my problems, or my mom doesn't want to hear about it, and sometimes getting that family involved so that they can learn how they can support that person is really important. So even friends can be a counselor. It doesn't necessarily have to be a licensed professional. Empathy is not merely having had a similar experience. It's being able to understand what the person struggling with the addictive disorder might be experiencing and how hard it is for them to go through. And people engage in change talk and resistance talk. So I have people that actually attend treatment right now, and they have no intentions of changing at all, and they let us know very clearly, but they're attending groups and doing what they need to do. So as long as they're meeting their legal requirements, it's a choice that each individual has to take on their own. Next. Okay, the interview skills. When you're doing screening or assessment, it's not necessarily a counseling session. But when I talk about micro-counseling, these are being able to apply your basic counseling principles. And I often would refer to that as person-centered counseling, which is your basic skills of listening and reflecting and being supportive to the person. Maybe, making sure that you're understanding the client and vice versa. And it also involves some motivational interviewing. Next. Micro-counseling skills are something that was defined by Alan Ivey. He is a distinguished professor from the University of Massachusetts in Florida. Next. Micro-counseling is an analysis of counseling skills that looks carefully and in great detail at the elements of the counseling relationship. Regardless of the aims and methods of a counseling relationship, understanding its micro-elements helps counselors improve their counseling effectiveness. Next. The first would be attending and attending behavior. So when the counselor is attending, the counselor's interest in the patient is demonstrated by having eye contact, their body posture, and accurate verbal following. And the attending behavior would be, you would be encouraging the patient to disclose more. And again, the active listening. But coming back to the attending piece, some Native American tribes have beliefs that we don't make eye contact. And I've done a lot of counseling with, I want to say, especially Native youth who don't do a very good job of maintaining that eye contact. So I've even learned, as I've worked with people from home, that just because someone isn't looking at you directly in the eyes does not mean that they're not listening to you. So some people that aren't aware of our cultural norms and behaviors is they may misinterpret that as somebody who's like not interested, when actually they're listening. They just have a different way of doing it. Next. When doing these interviews, you would rather use open questions as much as possible. That is using questions that will lead them to give you more than a yes or no answer. So these are questions that can't be answered with a yes or no, and offers encouragement, and the patient will speak a little more freely, like, you know, I'd like to hear more about that. So can you tell me more? Some closed questions focuses on the dialogue. Have you seen a doctor in the last year? Yes or no? Do you smoke cigarettes? Yes or no? So these are just brief responses to questions that doesn't elaborate much, and tends to turn the focus on the professional and away from the patient. Next. Patient observation skills. This is looking at a lot of the nonverbal behavior, and this is 85% of all of our communication. So being able to read people's behavior is real important. Their verbal behavior, there may be some key words that are used. There may be discrepancies in the patient's communication. There may be mixed messages, contradictions, conflicts, and incongruities. One thing I've really struggled because of the COVID, I've had to do some assessments online and over the phone. So I kind of struggle with that because I can't see the person and how they're doing. But with Zoom, I'm able to see them more. So I had a request yesterday from a patient who has an assessment, and they are afraid of the COVID. So they're like, can I do this on Zoom? So we do offer that. So I agreed to that. Next. We want to be encouraging by paraphrasing and summarizing, and sometimes people refer to it as parroting, back what you're hearing to make sure that we're understanding them correctly when they answer the questions that are being asked. Next. We want to be reflecting their feelings. This is the patient's feelings, either stated or implied, as expressed by the counselor. And feelings of the patient can be, again, nonverbal and verbal. So some of these people, this may be their third or fourth time coming in for another assessment, and they've had treatment in the past. So they may struggle with shame, embarrassment, and just being able to put them at ease and reassure them that, you know, this is something that they can change, and this is, you know, their life doesn't always have to be this way, and to give them some hope for a better future. Next. And reflecting meaning. Finding the deeply held thoughts and feelings underlying life experience. Paraphrasing is to thoughts as reflection is to feelings. So what I hear you saying, am I hearing you correctly when you say this? breaking down complex behaviors into parts. Next. Empathy. And one way I described this to one of my clients the other day was putting themselves in somebody else's shoes and trying to imagine what that might be like for that person. So this is understanding what the patient is experiencing and putting yourself in their place, how difficult that must be. Functions of empathy: it builds a firmer relationship with the patient, enables the counselor to better understand the patient's behavior. Common problems with conveying empathy could be language and cultural differences between patient and counselor. And that's where I was describing the difference between eye contact. And this is really one of the basic skills of counseling by Carl Rogers, who is the person who came up with the person-centered counseling. Is being empathetic is real important. So, and that's just being genuine when you're with someone trying to help them. Next. The next section here is a little bit on the motivational interviewing. This was created by William Miller and Stephen Rolnick to help get clients considering that they may have a problem and what they want to do to change it. Next. The history of this is from William Miller. He originally developed the motivational interviewing to increase the motivation of patients with issues related to alcohol problems to change their behavior. As part of this process, Miller found that approaching patients with a modified patient-centered approach increased the impact of the interview. What has evolved is a communication style and focus that increases the patient's motivation to work on their problems. Next. Motivational interviewing, or MI, as many people refer to it now in the counseling profession. If motivational interviewing is a way of being with people, then its underlying spirit lies in understanding and experiencing the human nature that gives rise to that way of being. How one thinks about and understands the interview process is vitally important in shaping the interview. Next. Motivational interviewing is a patient-centered approach. Increases the patient's response to screening and assessment and adherence to treatment. It improves treatment outcomes by enhancing the motivation to change. And back up for 1 second. This motivational interviewing, when we see that first bullet there that says patient-centered, again, that's also person-centered. And my agency that I direct, we are CARF accredited, so that's an international accreditation, and this patient or person-centered approach is required to meet international CARF accreditation, for those of you that might be interested. You can go to the next. The rationale is clinicians commonly think that they are already practicing motivational interviewing when they screen, assess, and treat. What makes motivational interviewing a unique counseling approach is how its skills are employed by clinicians. Motivational interviewing requires attention to timing issues, specific strategies, application methods, and maximizing the effectiveness of these skills. Next. 2 phases of MI assist in screening, assessment, and patient change. The first is building the motivation for reliable assessment and significant change by asking some open-ended questions, affirmation, reflections, and summary. The next is strengthening their commitment to change, building on the patient's motivation and resolve to change by using change talk. Next. Basic principle of motivational interviewing is to express empathy, develop a discrepancy, again, letting them know that what they're going through must be pretty hard, and they may be facing some legal charges, and how are they coping with that. But then looking at the discrepancy, as I said, I see many patients who come in and they have maybe 2 DUIs on the table that they're being assessed for. And they may sit there and say, I don't have a problem. And so then I'll come back and say, reconsider your response, because these legal situations that bring you here because of your use, do you see the connection there? So it's getting to help them realize that, they might not be sitting there if they hadn't had any problems with whatever substance they were using. And to roll with the resistance, now called dancing with discord. So some people may not be willing to fully engage in treatment, and that's just based on what options are available to them as to how much you can roll with that. Like I shared with you, I have a gentleman who comes to treatment regularly, and he is very open about saying he's just doing what he has to do because he doesn't want to change. But I keep hoping over time, him seeing other people actually changing their lives is going to motivate him a little bit. The next one is to support the self-efficacy and optimism of the client. So you want to give them some hope for the future and focus on the strengths that they have that can take them to where they want to go. You always want to avoid argumentation and direct confrontation, because that's when they shut down and they may just walk out the door. Next. Motivational interviewing is a fundamental approach that involves the collaboration with the patient and the counselor working together, evocation and suggestion, and autonomy, self-rule. Again, it comes down to patient-centered, person-centered, where they feel like they're in charge of their life and they're taking control and you're taking their input seriously. The 4 principles, again, are express empathy, not sympathy. Dancing with the discord, knowing, they're not exactly happy about this, but, we'll just go with it. And develop discrepancy, help them to see why substance use doesn't fit in their life. And looks like a typo here. That's just there again. Sorry about that. And to support their self-efficacy, let them know that you believe in them and that they can do this. Next. This is a brief screening tool with the acronym called FRAMES. And the first one is F for feedback of personal risk, of what this might be doing to, the person's life, their job, their home, anything that their substance use may be affecting. Responsibility of the patient, that this, re-emphasizing that, their use is their responsibility of how they choose to cope with it. And A is advice to change, offering them some advice to change. M is the menu of ways to reduce drinking. E is empathetic counseling style. And S is the self-efficacy of the patient, which comes up with FRAMES. Next. There are differences between screening for substance use disorders and assessment of substance use disorders. So if you look at this chart here, and you look at the time on the left-hand side, and on the bottom there, the comprehensiveness of the assessment. So if we're doing screening and you look at the time, it's not going to take very long. This should be something you can do in 5-10 minutes. The diagnostic assessment, you're going to take a little longer. We may take Some of my counselors take up to 2 hours, and sometimes they have to schedule another appointment because they didn't get to finish and they still have some work to do. And at the final end, that takes even more time, is the personal evaluation and the treatment planning. So this is where you want to look at the level of care they might need, and as far as the evaluation, we want to look at the type of use disorder that they have. Is it mild, moderate, or severe? And the treatment planning that will be involved. Do they need intervention? Do they need a low level of treatment? Do we need to get intensive? Or is this somebody we need to be looking at residential and our hospitalization in addition to that? Next. The difference between screening goals and assessment goals. Screening is designed to reflect the likelihood of the presence of substance abuse. Assessment is designed to provide a much broader range of information on degree, kind, causes for, and possible treatments of the abuse. And a lot of mental health or health professionals in the medical profession are trained to use some screening tools. I've had a client or two come to get an assessment because they were referred by their medical doctor. And they will tell me, my doctor said I should come get an assessment because I went to the hospital because I was having withdrawals, or I got sick from using, or I had an accident when I was drinking. And I like that the medical professionals are doing some brief screening. Next. More differences in the screening goals and assessment goals. Screening instruments are typically brief, 4 or 5 questions, yes or no answers, can be administered by anyone, and are obvious in their intent. Assessment instruments are more time-consuming, require more complex historically based information. We'll look at your family history. We'll look at your substance using history. When did you first start? When did you start to drink regularly? When did you start to drink more? Benefit from use is experienced by trained evaluators. So assessment is determined by usually each state, and I'm in Wyoming, and we use the Addiction Severity Index, and the state substance abuse department requires the ASI be used to qualify as an assessment in this state. So every agency in Wyoming uses it. And these are not always obvious in intent. Next. When screening for substance abuse, we are identifying possible substance use disorder. We are doing a behavioral observation, observing the patient. We would like to have collateral informants, eliciting information from friends, other providers, corrections, public records, and spouse and relatives. I have a really good gentleman who screens our people at the front desk for treatment. So, he'll ask them, is this a DUI? Yes, you need to bring us your driving record. Maybe they didn't tell us this is their 3rd or 4th one, but the driving record will show that. Are you on probation? Are you on parole? Can we get your PSI so that we can get your background information? So I've been doing this for 19, almost 20 years, and I still get people that lie. And I'm not a lie detector. So sometimes I believe people's story and then something comes back later. So I will tell the client, this is my recommendation unless I get some conflicting information from your probation officer, your parole officer, your attorney. And I just had that happen recently where I was in the middle of writing up the assessment and my assistant told me the probation officer called. That's again, I had to reiterate to them how important it is to get us that background information on them. So I had to change everything because the client that I interviewed lied on just about everything to avoid any treatment recommendation. And I put that in my report. I say that they intentionally misrepresented themselves to avoid any treatment recommendation or diagnosis of a disorder. Laboratory tests. Sometimes I send people to go get a physical so we could look at their blood work. Is their liver functioning right? Are their kidneys functioning right? Some people can cause a lot of health problems from substance use. They can cause heart problems. They can cause cancers. So alcohol can really do a lot of damage, and so can other drugs. Some self-report screening measures. One is the CAGE. It is also adapted to include drug use. And there's this RAP S4. Most of these are free online. The MAST and the MAST2, the TACE, the TWEAK, the SBIRT, and the AUDIT. And the SBIRT is probably one of the most common ones that I've seen used across the country. And this is the one that I was talking about. Medical professionals do use it to screen people in the hospital. And if it's not the doctor themselves, the nurse may be trained to use the screening instrument to assess if this person might be struggling with some substance use problems. Next. Here's the CAGE aid questionnaire. It is a cut point of 1 detects about 90% of those with an alcohol-related disorder, with 48% false positives. The question would be, have you ever felt you should cut down on your drinking or drug use? Have people annoyed you by criticizing your drinking or drug use? Have you ever felt bad or guilty about your drinking or drug use? Have you ever had a drink or used drugs first thing in the morning to steady your nerves and get rid of a hangover, known as an eye opener? Next. The RAP S4 this is from an article by Sherpatel in 2002. The sensitivity is better than the CAGE with good specificity. Addition of QF questions outperforms the CAGE for alcohol abuse across a wide range of groups. So it'll look at the last year. And the ASI that I use also covers the last year. It might say in the last 6 months or the last year. So during the last year, have you had feelings of guilt or remorse after drinking? A friend or family member ever told you about things you said or did when you were drinking and you don't remember? You have some amnesia? Have you failed to do what is normally expected from you because of drinking? You're not going to work, not spending time with your family, like you said you were going to take the kids to the movies or something, and you didn't do it because drinking distracted you. Do you sometimes take a drink in the morning when you first get up? The starter. And the QF of consumption of alcohol, which is quantity and frequency. So how much do you drink when you do drink? And how often do you drink? Next. The MAST is the acronym for the Michigan Alcohol Screening Tool. And there are just a few questions here. Do you feel you are a normal drinker? Does your wife, husband, parent, or other near relative ever worry or complain about your drinking? Do you ever feel guilty about your drinking? Do your friends or relatives think you are a normal drinker? Are you able to stop drinking when you want to? Have you ever attended a meeting of Alcoholics Anonymous? Has drinking ever created problems between you, your wife, husband, parent, or other near relative? Next. Here is the MAST 2 that gets into questioning a little bit more, have you ever gotten in trouble at work because of your drinking? Sometimes I do get employers that do drug testing at their jobs, and they send patients to us for employer assistance programming. So we evaluate them and recommend treatment for them. And some of them are, they failed the UA at work, or maybe they got a DUI or some legal involvement that an employer might be concerned and say, we think you need to go get an assessment. Have you ever neglected your obligations, your family, your work for 2 or more days in a row because of your drinking? Have you ever gone to anyone for help about your drinking? Have you ever been in a hospital because of drinking? Have you ever been arrested for drunken driving while intoxicated or under the influence of alcoholic beverages? Have you ever been arrested, even for a few hours, because of other drunken behavior? Next. This one here was new to me. It's alcohol screening instruments for pregnant women called the TACE. So the questions on the TACE would be, the first one is looking at the tolerance. How many drinks does it take to make you feel high or to get a buzz? Have people annoyed you by criticizing your drinking? Have you ever felt you ought to cut down on your drinking? And the eye opener, have you ever had a drink first thing in the morning to steady your nerves or get rid of a hangover? And if we're looking at a pregnant lady, we want to do what we can to prevent fetal alcohol syndrome or fetal alcohol effects of the unborn child. Next. Another screening instrument for pregnant women is the acronym of TWEAK. Looking again at tolerance. How many drinks can you hold? Worried. Have friends and relatives been worried or complained about your drinking in this last year? Eye opener. Do you need to have a drink in the morning when you get up? Amnesia. Has friends or family ever told you you said or did things when you were drinking that you don't remember? And cut down. Do you ever sometimes feel the need to cut down on your drinking? Next. This is the SBIRT, and this is what I was sharing a little bit earlier that is real common with medical professionals in assessing people for possible substance use problems. And what it really means is screening, brief referral, and brief intervention and referral to treatment. So this is an evidence-based approach that identifies patients who use alcohol and other drugs at risky levels with the goal of reducing and preventing health consequences, diseases, accidents, and injuries. Risky substance use is a health issue and often goes undetected. For men, how many times in the past year have you had 5 or more drinks in one day? So, you had none or 1 or more. Women, how many times in the past year have you had 4 or more drinks in a day? So this is assuming that most men will drink more drinks in one day in the past year, and the past year for women having had 4 or more. The next slide. Looking at drug use, we'll look at this. The SBIRT will address recreational drugs that include methamphetamines, speed, crystal, cannabis, marijuana, pot, inhalants, paint thinner, aerosol, tranquilizers, barbiturates, cocaine, ecstasy, hallucinogens, LSD or psilocybin mushrooms, and narcotics such as heroin. How many times in the past year have you used a recreational drug or used a prescription medication for non-medical reasons? None or 1 or more. Next. Another screening instrument uses the acronym of AUDIT, the Alcohol Use Disorders Identification Test. Should be administered to adult patients who screen positive on the pre-screening for alcohol use. Side 1 contains the screening questions, and Side 2 contains instructions on scoring and interpreting the audit. Next. Using the DSM-5 in diagnosing substance-related disorders, the chapter on substance-related and addictive disorders includes 10 substance-related disorders. They are alcohol-related, caffeine-related, cannabis-related, hallucinogen-related, inhalant-related, opioid, sedative, hypnotic, or anxiolytic, stimulant-related, tobacco-related, and other substance-related disorders. One of our state agencies that provides funding to my nonprofit agency requires us to track tobacco users and also diagnose them for tobacco use disorder if they are regular users of tobacco. We haven't had to diagnose caffeine. Next. Substance use disorders. Almost all substance use related disorders in the DSM-5 include substance use disorders, substance intoxication, and substance withdrawal. Almost all specify if the substance use disorder is to be rated as being mild, moderate, or severe. Exceptions include caffeine use, there are no severity ratings. Hallucinogen use disorders, there is no intoxication or withdrawal. Inhalant use disorder, there's no intoxication diagnosis, and tobacco use disorder, there is no intoxication. Next. Alcohol-related disorders include mild, moderate, and severe, alcohol intoxication, and alcohol withdrawal, and an unspecified alcohol-related disorder. And when we say unspecified, they may not meet criteria for a substance use disorder. This might be someone who's perhaps relatively young, or someone who seldom drinks at all, but they've had some type of problem and they've had to come in and see us because they got a DUI or something happened and they were involved, so the assessment might not give us enough to diagnose them with a use disorder. Next. When we're looking at the use disorders, when I say specifiers, like I said, there's the mild alcohol use disorder, and they would have 2 or 3 symptoms. There is a moderate alcohol use disorder of 4 to 5 symptoms are present, and the alcohol use disorder of 6 or more symptoms are present. And my agency, I didn't get to bring it today, but I may send it in later. We have a DSM check sheet that has all of the substances on the sheet, and then there's one for other. And we have all the 11 areas where you want to ask questions, like you're having trouble stopping, are you spending more time using, not fulfilling responsibilities, you can't function unless you're under the influence. So we look at all the criteria. So if they have 2 to 3, we would diagnose that person with a mild use disorder, 4 or 5, and then the 6 goes up to severe. Next. The alcohol use disorder is a problematic pattern of alcohol use leading to clinically significant impairment or distress as manifested by at least 2 of the listed symptoms. and occurring within a 12-month period. Next. Symptoms of alcohol use disorder. Here's the criteria. Starting with taking alcohol in larger amounts or over a longer period of time intended. Even when I go out to a bar or party, having resolved to drink no more than 3 beers or spend no more than 2 hours, by the end of the evening, I discover I've consumed 10 beers over 4 hours. Is there a persistent desire or unsuccessful efforts to cut down or control alcohol use? Time and again, I've tried to control my drinking, but I've never been able to do so. Spending a great deal of time and activities necessary to obtain alcohol, use alcohol, or recover from its effects. Alcohol takes up a lot of my life, with getting the money to buy it, spending time at bars consuming it, talking to friends, and getting over whatever hangover I might have developed from my drinking. Next. Is there a craving or a strong desire or urge to use alcohol? And this is when I haven't been drinking for a day or two, I'll begin to experience strong cravings for alcohol, which stays with me until I take a drink to get rid of the craving. Recurrent alcohol use resulting in a failure to fulfill major role obligations at work, school, or home. It will sometimes happen that my drinking makes it impossible for me to go to work, take care of my family, and it makes me feel terrible, but I still do it. Why? Next. More symptoms of the alcohol use disorder include continued use of alcohol despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of alcohol. Even though I have a tendency to become angry and sometimes violent when I have been drinking, I continue to drink and then to suffer the consequences of my anger and fights. Important social, occupational, or recreational activities are given up or reduced because of alcohol use. I used to like to dance and visit my friends and family, but since I started drinking so much, I've given up almost everything that doesn't involve drinking. Recurrent alcohol use in situations in which it is physically hazardous. I've had 3, that should be DWIs, and have been in 2 accidents because of my drinking, in which I was pretty seriously injured. Every time I am able to drive, I've been drinking. Next. Symptoms of alcohol use disorder. Alcohol use is continued despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by alcohol. Even though I almost always get very depressed after I've been drinking for some time, I continue to drink. I don't know why. It doesn't make sense to me. This question I really look at when I get to the medical section of the ASI, and they have diabetes, they have heart problems, they have liver problems, whatever that is caused by alcohol, even high blood pressure. These are health conditions that they should not drink. And even if they have a psychological problem where they're on psychotropic medications to control whatever symptoms it is they need to reduce, and they continue to drink because whatever medications they'll be taking, they won't work, or either they'll become more sick from continuing to drink knowing that they have these problems. Next. More symptoms. Tolerance. There's a need for increased amounts of alcohol to achieve the desired effect. are a markedly diminished effect with continued use of the same amount of alcohol. So it's now taking them more alcohol, or they're using more amounts of distilled alcohols. And withdrawal. The characteristic withdrawal syndrome for alcohol or a closely related substance such as a benzodiazepine is taken to relieve or avoid withdrawal symptoms. So these people may be experiencing delirium tremens where they may be shaking really bad, be really severely ill, and all they want is a drink. And I remind people that come to our 8-hour DUI class that when you have a hangover, that is a withdrawal. That is your body wanting more alcohol. And for note, physical withdrawal from drugs like alcohol and benzodiazepines can be life-threatening. Medical support and management must take priority. And I didn't know this early in my career, and there have been situations where I now realize that I maybe should have offered that person some alcohol a little bit just to get them to the emergency room. And if you have a detox center, most places where I recommend people here, because we don't have a detox center, is the emergency room, because they have medications that can help them to get stabilized. Next. Alcohol use specifier changes. The DSM-4, we used to diagnose people with dependence. That would be physiologic dependence or without physiologic dependence. And we also diagnose them with abuse and not dependence. DSM-5 changed that to severity specifiers with the mild, moderate, and severe. And we went over all the symptoms and how many it takes for each one. And the patient status specifier. So if they're in early remission, they've recently stopped and haven't drank in probably the last 6 months at least. And sustained remission would be about a year or more of no use of the substance. And are they in a controlled environment? Some of these people might meet severe criteria, but they're incarcerated right now, so they're not being able to use because of the controlled environment. Next. Okay. Looks like we've only gone up to 12. Is there any questions or comments about the stages of change, motivational interviewing, frames, differences between screening and assessment? Any questions?
Someone asked, why are there no tools that are culturally encompassing and take into account minorities, especially Native norms? These are all mainstream tools, and we are forced to use them.
I get you. These are based on evidence-based studies, and I agree. I do not know that there are any specific tools for Native Americans, but most family members know when there's a problem. You know, this is not normal. They're just drinking all the time. The ASI, the Addiction Severity Index, actually has a tool in there that is specific for Native Americans, and the programs on the reservation where I come from, both tribes use the Native American questionnaire that is incorporated into the Addiction Severity Index. And this is free. You can access the Addiction Severity Index online, and you can access the Native American version that goes along with that. And that Native American version looks at what tribe they come from. Do they live on a reservation? Do they speak their language? Do they participate in cultural events such as sweat lodge or other ceremonies? Do they eat traditional foods? And I'm trying to remember what else there might be on there. But I think it's a pretty good tool, and the reasons the tribal programs are using that Native American supplement to the ASI is to pick those individuals out who might be appropriate for some more cultural activities that take place in the tribal treatment programs, such as the sweat lodge, or having the elders be there, or doing some arts and crafts, or even learning the language. So there is I want to say best practices from tribes that supports the use of integrating cultural practices into treatment. And I have seen some people not enter into any treatment, but just participating in tribal cultural activities such as the sweat lodge, or any other ceremonies, that it makes a huge difference.
Yeah, for sure. We had another question, says, I was wondering if there's a treatment for a person that knows they need help, they know they have a drinking problem or habit, but they haven't actually had a drink in months because of their living situation. They may have wanted help, but they weren't currently drinking.
Can you ask that one more time?
Yeah. I was wondering if there's a treatment for a person that knows that they need help. They know they have a drinking habit, but they haven't had access to a drink in months because of their living situation. He wanted help, but wasn't currently drinking.
Okay.
So they don't technically meet the DSM-5 or other assessment red flags because maybe they haven't had a drink in months, but they
this would meet the unspecified disorder. And like you said, they haven't been drinking for a while, but they know they have a problem. And I have a young lady who we work with the correction centers here in Cheyenne, and a lot of our people transition from prison, or either they're at this place in lieu of prison, and if they don't follow the rules, the next step is total incarceration. And some of them may have use disorders, but again, because they're living in a controlled environment, they're not having a problem. So oftentimes when I'm doing that assessment, I do ask them, I know you're in the correctional treatment center right now, and if you weren't there and this was available and there was nothing stopping you, would you? So sometimes it's just changing those questions that we are asking the person. And when you say treatment for them, they would probably start with counseling. And if they've been able to not drink for that time, it's like, what have you been doing that has been keeping you clean and sober all this time? Because something's working. And then when they know they have a problem, that's why I talk about looking at the underlying issues of, when I worked in residential treatment, we had patients who successfully completed a treatment program. This might be their last day in the program, and they disclose a huge trauma event, like on their way out the door practically. And so I've learned over time to try to get to those sooner rather than later, because that is going to continue to always affect that person. And using a lot of times is how they cope with that use disorder, by coping to treat their own depression, escaping from their own trauma.
Definitely. We had one more question. They said, can you elaborate on how the controlled environment affects the evaluation process for those incarcerated?
When we get people from prison, and we call it CTC here because it's the Controlled Correctional Treatment Center, they have to come and get an evaluation if they don't come out with one. And when I ask that question of them, I tell them, because you're in this center for so long, Or I've had a young lady who's been in prison for 8 years, and she's like, I don't have a problem. And I'm like, well, before you went to prison for all of these charges for this drug that you were selling. And you might not have a problem now, but if we opened the doors tomorrow and you were free to go, you know, what are the chances that you might pick up again and you take up where you had left off?
Definitely.
And then when you diagnose that person, again, there are those specifiers. They may be in sustained remission, which means, you know, they've had years of clean time and clean sobriety. So it's really looking at the specifiers. I see someone's comment up here of peer supports work very well on our reservation. And I love peer support. The state here in Wyoming requires my program or any program that receives state funding for treatment to offer peer support. I was going to face a budget cut if I didn't incorporate peer support workers into my program. And on the reservation, I really liked them because we had a male and we had a female. And so the clients are better able to relate to them because people that become peer support are sober and clean themselves, and they have to have a minimum of 2 years of sober and clean time to take the training, to get the training to become peer support. And we have a lady in our program who's had several years of sobriety, and she does really excellent work. And, you know, maybe these clients don't want to talk to us because we're the counselors, so they may feel more comfortable talking to the peer support. So the peer support is always available. Her number is always available to anyone that might need to reach out to them.
Sure. Someone asked, are there virtual group supports?
I have heard there are virtual AA and NA meetings. I personally haven't gone online to see, but I do know they exist because of the COVID.
If anyone has any other questions, please feel free to post them. Someone commented, we use peer support here in Oregon as well, invaluable. Awesome.
Okay. Yeah, they are really awesome. I'm seeing some people are posting White Bison has Zoom, and White Bison is basically the 12 steps that has been modified to be more culturally supportive to Native Americans. And I've met the leader of this, Don Coyhus. He's really an awesome person, and he also speaks from his personal experience. Okay, yeah, someone just posted there's talking circle support groups online. Okay. I guess that looks like that's most of the questions we have. So if that's it, we'll leave off there. And this is a series, so there will be some more sessions coming up. I think once a month I'll be presenting a topic, and all of these topics that are being presented are meant to help those who are studying for the substance abuse counseling exams. So this is what this information is being provided for.
We have one more question. Do you treat many veterans in your practice?
We get veterans from time to time, and I've treated more on the reservation than I have here off the reservation. And we often refer our veterans to the Veterans Center because I live in the state capital. The VOA is right here, and the Veterans Administration has amazing support for them. And so I always refer them to that program, but they're free to choose to stay with us if they choose. But I really like to hook them up directly with the Veteran Affairs office so that they can get everything that they could possibly receive.
Wonderful.
Thank you guys for taking time to attend this, and I look forward to seeing you again next month when we cover another series.
Awesome. Do we have time for one more question?
Sure.
Okay. Are there programs that use teenagers as peer support role models?
I saw that, and to be honest, I don't know of any. I don't work with adolescents now as much as I used to.
Yeah.
Huh. Okay.
Oh, did you want to continue further? Sorry, I didn't.
You know what? I thought this was the end. That's why I stopped there.
Would you like to continue? Looks like there's some
Yeah.
pretty cool stuff up ahead.
Okay, yeah, I didn't see that. I when you were switching through those, I was like, whoa.
Yeah.
So, I apologize. I thought that was the end. Okay, treatment options are, I guess we have some more slides. How much more do we have to go? You know?
We have about a little over 15 minutes, so it'd be perfect if everyone wants to stick around.
Okay. There is, yeah, we should have had the questions at the very end of this slide presentation and not there. The treatment options are detoxification. Like I said, some places have a detox centers, and I don't know of any in the town that I am in. And when I used to work close to the reservation, we had a detox center there, and I actually did my very first internship there, so I got to learn a lot about detox. There is pharmacological maintenance, and that is prescription medication, naltrexone, and there are some other medications, and my mind just went blank. But the naltrexone has been shown to be real effective in helping those off of opioid use disorder. There are outpatient treatments. The program I run is an intensive outpatient treatment center. Yeah, there it is, Suboxone. Somebody, Miss Donita King. And I do in an outpatient treatment program, and we do anywhere from 0.5, which is early intervention, to a level 1, which is maybe anywhere from 8 to 10 sessions. And then our intensive outpatient program is 3 hours, 3 times a week for 36 weeks for the men and 42 for the women. And that's just at my program. The reason we have more for the women is the lady who runs our program, she has her own curriculum, so she covers a lot of other things, and she assigns assignments that has to be completed for them to finish, and she really does do a great job. Some people require partial hospitalization, and those are agencies that require them to be under some medical care for medical problems that they might have. So they will need to check in regularly with a nurse, physician, psychiatrist. And then, of course, we have the inpatient and residential treatment programs. And they all run varied amounts of time. They used to say the 28 days wasn't long enough, and so a lot of programs went longer. And then because of the budget cuts that we've experienced throughout the state here, a lot of those have shortened the time on those. And the continuing care and community-based support groups. Our continuing care at my agency is also 36 weeks. And in the town that I'm in, of Cheyenne, Wyoming, We have them in there for 36 weeks, and as far as I know, we have the longest continuing care program. And the reason we do that is research has shown the longer that they're engaged in treatment programming, the better success that they have. Go to the next slide. Some evidence-based treatments for alcohol abuse. Often when we write notes for the groups and counseling that we do, we often have to list what was all provided. Motivational enhancement, cognitive behavioral. A lot of addiction treatment is cognitive behavioral coping, so that we're looking at those thought disorders that they could have, or thinking problems, corrective thinking that needs to be done to change how they've been behaving. 12-step facilitation. My agency doesn't require our participants to attend. The court treatment program that I oversee doesn't require it, but from personal experience, those that I know who get involved in 12-step have greater success than those that don't. Community reinforcement and the pharmacological treatments, the opioid replacement, the medication-assisted treatment, we refer to another community-based medical program here in our town. You can go to the next slide. Here's a continuum of care that shows the different intensities of treatment. So if you're looking at the left-hand side, there's the emergency hospital room. And when people are experiencing severe withdrawals, I often refer them to the hospital. And then there's the inpatient hospital detox. Like I said, I don't know that there's a detox, but I do know the hospital will accept some people that are having severe withdrawals here. Then we go on into, moving to the right, the residential treatment. I see a wilderness program here, and I don't know that any of our programs here in Wyoming offer that. I have read about some that take place in different parts of the country that offer some outdoor experiential activities and recovery residents. These would be the sober living houses. And then moving down the continuum to lower acuity would be low intensity recovery residents. Again, they're still transitioning into the community. One of the programs here helps people, well, they're actually required to get a job because they have to pay a certain amount of money to live in the sober living environment. And then to outpatient treatment, where people come in at set times to attend classes to learn how to manage their lives and improve their lives. And then the self-help groups, talking circles, AA, NA. And then there's another program here in our town called Recover Wyoming, and they have some peer specialists that actually run that program here in this town. Next. Evidence-based psychosocial treatments for alcohol abuse. Again, there's a motivational interviewing, heightens the patient's motivation to stop drinking so heavily, and that will improve their quality of life. Again, the cognitive behavioral coping skills therapy. Next. Some more evidence-based treatments, 12-step facilitation. Some of my counselors, one of my people who is a counselor has been in recovery for over 20 years, and she incorporates some of the 12-step into her treatment program. A community reinforcement approach, so giving them access to community resources, Voc Rehab, the Department of Family Services, educational programming, and the behavioral couples therapy. So this could help a couple with interaction. Next. These are the pharmacological treatments. The anxiolytic, the BuSpar, helps reduce alcohol consumption. Medication-assisted treatment, the naltrexone and Suboxone for the opioids, reduces craving following detoxification and increases the likelihood of abstinence and recovery. Next. And back to thoughts and questions. And the one thing that I always keep in mind here is I'm presenting to Native populations, and on the reservation, the treatment programs do include, we bring elders in to spend time with the clients that are in treatment. We hook them up with the language classes. They may do some crafts. The Shoshone Recovery Program has one day of the week where it's mostly women that come in, but some men come in too. They may go outside and, redo the sweat lodge outside and maybe go cut wood for the sweat they're going to have that week and get things ready. And then the women, a lot of them come in and they sew star quilts, they bead earrings, they make moccasins, and it's not evidence-based, but this is what we call culturally based best practices, and research is really supporting the sweat lodge in recovery treatment programming to be one of the most successful interventions we can offer. And there are other things, and so with 560 federally recognized tribes, we have our different practices, our different beliefs, our different ways of doing things. So I always like to preface my presentations of I don't speak for everybody, and then my tribe, there are things that I am not supposed to share or talk about out of respect for my people. And so those of you that know what your tribe, what other things there are, those are also very helpful in helping people, because a lot of times that spiritual component of this individual's life is gone. They're not involved in things anymore, and so it's bringing them back. And I like to look at it as reconnecting them, because I've even worked with families who have never been in a sweat lodge, or maybe they haven't been given a native name, and for a lot of natives, that name really gives them a sense of identity and helps them to be proud of being a Native American. And so we've had naming ceremonies in some of our sweat lodge for some of our clients. And I've met parents of, when they were talking about adolescents, when I worked with the juveniles in the juvenile programming, some of these kids' parents who did get involved said, we weren't taught these things. I didn't learn these things. And they're always real thankful to learn and be a part of it. I just thought I'd add that, because I always think about how we can help Native people. And that's
if
all
anyone
I
has
have.
any other questions, please feel free to post those. But I'm going to post the GIPRO survey one more time. This is a quick survey that really helps our center and just takes a few minutes. But someone commented, learning to introduce yourself in your native language is very powerful also. I agree. For sure. Bringing in the culture is so important. Yes, for sure. Okay, well, thank you so much, Avis. We really appreciate you being here. Thank you to all our viewers as well. We really appreciate you joining us today for this session. And we will have more events coming up, so please feel free to check out our website for next month's event.
Okay, and in my tribe, we don't have goodbye words. We say we'll see you again, and we say hacha nahabethan. And so that means we'll see you again. So I look forward to seeing you guys in my next month's session.
See you, everyone. Thanks again, Avis.
You're welcome.